intensive care unit, you should understand risk versus benefit. Always we do that. Our entire thinking is it risky to do this? Is it risky to do this? Is it beneficial to do that? Right? So that is why you should understand when I can move from here to here to here to here. Okay, it's very important. And remember this, when you're doing this versus this, the risk is lesser here, risk is more here. Okay, clear on this? So as I said, the first is a non-negotiable. I mean, that is done for all patients. More so our intensive care patients, you cannot move from this tier to this tier if you are going to hyperventilate your patient. If this patient's oxygenation is poor, you cannot move from this to this because that is non-negotiable. Are you getting the point? Are you getting the point? Clear? So you have to first get this right. And again, I'm telling you what is T0. T0 requires you to have a propped up position. It requires normocapnia, normoxia, normotension. You cannot go from here to higher therapy unless this is there. अगर ये नहीं किया तो मतलब आगे कुछ मतलब नहीं है उसका. So your first thinking when you are working with intensive care unit patients in raised ICP should be this. So how you going to modify this? The moment you have put this patient on a ventilator, you are looking at the ETCO2, PCO2 to ensure that the PCO2 is in the normal range. And what is normal? So what happens? What is normal? Sorry, I have a lot of numbers.
35 to 45.
35 to 45 is your?
Normal PCO2.
There are two things: PaCO2 and ETCO2. What are we trying to look at?
PaCO2.
Yeah.
What is ETCO2?
The carbon dioxide.
It is end-tidal carbon dioxide. It is end-tidal carbon dioxide. What is the? Is it the same thing? What is different? Which is more, ETCO2 or PaCO2?
PaCO2 is more. PaCO2 is more.
ETCO2 is more or PaCO2 is more?
PaCO2.
PaCO2. So ETCO2 is actually lesser than the PaO2 by 2 to 3. 2 to 5, 3 to 5 actually. Okay. ETCO2 is lesser than the PaCO2 by 3 to 5. Please, this is non-negotiable that you don't know this. Okay, you have to know this. Okay, your PaCO2, your ETCO2 is at least 3 to 5 millimeters of mercury lesser than your PaCO2. That means if your ETCO2 is 25, your PaCO2 is 28 or 30. If your ETCO2 is 30, your PaCO2 is 32 to 33 to 35. 30 whatever. Clear? That is non-negotiable. That's why your target, when you started by saying what is your target for normocapnia, now will now change from, it was you said PCO2 of 35 to 45, which means ETCO2 of 30 to 35, 37 to 40, 37 to 42. Okay? So you have to have a target ETCO2 of 37 to 42. That is normocapnia. Are you getting the point? 37 to 42. Very essential. Very, very essential. That what your targets for normocapnia are. 37 to 42. Clear on this? Clear on this? That's because there is a gap. And why does that gap come with him? Why is there a gap? Why is the PSO2 higher than that? What's happening here? Because there's a dead space contribution. The dead space contribution is what that is. So more the dead space, more the gap. So that's why the first thing you do when you have a patient who's come into the ICU with a traumatic brain injury or intubated is correlate your ETCO2 to the PaCO2. Correlate that. Because that is your moving target. You're getting the point? So the gap is regular or not is not certain. You understanding what I'm saying? You are understanding this or not?
Yes.
So you have to correlate that once the patient comes, you put them on a ETCO2, you find the ETCO2 to be 38. This is what you're saying, it's normocapnia. You have to verify whether this is normocapnia by doing a PaCO2. You understand? And look at that gap. So if say the PaSO2 is 42, so the gap is 4. The gap is 4. The gap is 4. That means the next tier of management, when I say what I need to change, I now have an idea what should be my number of my EtCO2. You're getting the point? Are you understanding what I'm saying? Huh? Now as a doctor, you should understand when does this gap widen. It's very many of times you will find that your EtCO2 is 38 and your PCO2 is 50. That means you might think that ये तो अच्छा है, normocapnic है, but actually inside the brain the PaSO2 may be 50 inside the blood. समझ में आ रहा है? So it's important, that's why to do an ABG in the first place. It's important to do an ABG in the first place because what you might think to be normocapnic may actually have been hypercapnic. Clear? Clear? This is very essential. So you just don't put the EtCO2, just don't put the ventilator and you say okay the EtCO2 is good enough. No. We are targeting the PaCO2. EtCO2 is a surrogate of your PaCO2 with a change of 2 to 5. Correct? And but that change is regular or not, you must know. And why is that so? Let's take the example of a patient who comes in from a road traffic accident. Okay, he's had a bus go over him and he's had a large brain trauma. Okay, that brain trauma has caused traumatic brain injury, caused diffuse cerebral edema. Okay, it's called diffuse cerebral edema. There is nothing correctable on that. It is a diffuse cerebral edema. There is no EDS, there is no SDS, there is nothing like that. It's a diffuse cerebral edema. He comes to the casualty and he's also had a fracture femur. Okay, now there's a fracture femur happening there. Okay, the fracture femur has caused blood loss and his blood pressure is on the lower side. So whenever the patient is in shock, the amount of blood going to the lungs are lesser, the amount of carbon dioxide going out is even lesser. So a person with low cardiac output, a low person with shock, a person with shock will not have the same EtCO2 reading than you have otherwise. समझ में आ रहा है? Clear on this? Am I clear on this? Huh? So his EtCO2 may show 20, but it might be in the body as 50. It might be 35, but the EtCO2 may be 70. Are you getting the point? So in that case, it becomes even more difficult. And it changes because it's dynamic, it changes. You correct it, it will again change. You correct it, it will again change. Are you getting the point? Huh? That's why the ABG becomes very important there. Now let's take the example that the patient has come into you and he had a IC bleed. Now IC bleed is come, you decided I put the patient on a ventilator and you didn't want to anticoagulate. Though you can anticoagulate them with a DVT prophylaxis within 48 hours. I decided no, I don't want to anticoagulate it because my neurosurgeon says don't do it. So now what has happened? Achanak sa this patient you are on the ventilator. You're on the ventilator and you are seeing EtCO2 25, you are seeing EtCO2 35, 40, which you wanted. Normocapnic, you have put the patient on the ventilator, so 37 chal raha hai, 37 EtCO2 chal raha hai. ठीक है? So you are okay. 37 chal raha hai, normocapnic. My first fundamental is right. Now you suddenly find that the patient's blood pressure is gone slightly changed. Okay, it has changed, and the EtCO2 suddenly gone down. What has happened here? What has probably happened here?
Shock, cardiac output has come down.
But what is this pulmonary embolism? The combination of the EtCO2 going down suddenly with the presence of slight changes in the heart or BP is usually pulmonary embolism unless proved otherwise. So if you have a pulmonary embolism, pulmonary perfusion is reducing. Since pulmonary perfusion is reducing, EtCO2 is changing. So PaSO2 will be markedly different. The PaSO2 may be markedly different. So if you have a situation in your ICU where you are actually looking at tier 0 management in a patient with raised ICP, I have to be very certain what is happening to my PaCO2 because the EtCO2 is just giving you a clinical indicator and you must know when the EtCO2 is changing or not changing or the PaCO2 may change. So in a patient who's got pulmonary embolism, the EtCO2 will not be mirroring what's happening inside the body. The gap will widen. Clear? The gap will widen. So you might think EtCO2 to acha hai, 35 hai, but it might be 60 because the perfusion is not okay. That's why EtCO2 is coming as 35. Getting the point? Getting the point? Huh? Let's take the other example. You have a patient who's on the ventilator and we are trying to monitor this hypoxia. Huh? because this patient had come in, he had an ARDS, you gave him a blood transfusion. This same patient that came to you had no problem with blood pressure. Okay, I initially had the blood pressure problem. Now because you have fixed the wound and you've actually put in a splint and you started blood transfusion, his BP has come up. And what has happened, unfortunately, because of blood transfusion, there has been a trolley. Let's take the example, there has been a trolley or a fluid overload, and now you start developing hypoxia. Okay, start developing hypoxia. What do you do usually when you have hypoxia? What is the things that you normally do when you have hypoxia, Dr. Ankita?
We start to auto.
Patient is on the ventilator. This patient is on the ventilator. We are looking at a patient who is on the ventilator. Patient is on the ventilator.
Yeah.
They have intubated. He had a fractured femur and a traumatic brain injury. He's just got raised ICP. He had low blood flow. That's why the blood pressure was 90 or 100. You've given him blood. In an hour's time, the BP has come up to 130, 140. But because of the blood transfusion and whatever trauma he had, he has now developed a kind of an ARDS. He developed a kind of an ARDS. Now you are still in the foundational therapy, right? You're in the foundational group where now you find that the patient is got hypoxic. That is, the saturation is now 80. 80. What would you next do usually in this case? In these cases, you will increase the FiO2, and then FiO2 के बाद भी अगर वो समझ लो 90 पे फर्स्ट है, you still want to go higher because it's traumatic range. You want to keep it more than 93. What do you do next? PEEP. You increase the PEEP. Correct. You increase the PEEP. Now here is where you have to be scared. Here you have to be scared because you are in the foundational therapy here. In the foundational therapy or in raised ICP, once you increase the PEEP, what are you going to expect with changes with respect to ETCO2? What can occur? What can occur? Avinash, what can occur? So, your mind will able to understand only what you see and what you understand. That's why what you understand.
ETCO2 will come down.
ETCO2?
If we increase PEEP, ETCO2 will come down.
Unlikely, no? If you're going to increase PEEP, the ETCO2 will not come down. ETCO2 may most often go up, no?
Yeah, ETCO2 will come down with your RR and your.
What if you are going to give PEEP, you are not ventilating. Ventilation is like this. If you're going to give PEEP,
Like, yeah, so there'll be more.
Okay, retention.
Avinash, you're working in ICU so long. Okay,
Yeah.
so PEEP will actually may cause.
ETCO2.
But what is our target? PaCO2. Our target is PaCO2. So again, you are now not knowing the relationship between ETCO2 and PaCO2. What can occur with higher PEEPs? What can occur with higher PEEP is you might actually cause over distension if you overdo your PEEP. If you cause over distension, if you overdo your PEEP, it will press the capillaries. It will press the capillaries. So the amount of blood going towards the lung will actually reduce. So the amount of carbon dioxide unloaded into the patient will reduce in the extremes of PEEP, and that ETCO2 will be very, very low, and the PaCO2 will actually be very, very high. समझ में आ रहा है? And explain this once more. Let's take the example that we are overdoing the PEEP. Overdoing the PEEP, which we don't know what you're doing. We are overdoing the PEEP. That means what has happened is, a permanent marker. Oh, this is a permanent marker. This will not go now. Oh God. Check it. How do they keep a permanent marker? What an asshole! Yeah. Who's this person? Why would you do something like this? Seriously, it's irritating. Yeah. No, it's okay. I'll just maybe this is another marker. If this works. Okay, take it. So if this is your alveolus, okay, and this is your alveolus reading is your capillary. What did we initially say? If the cardiac output becomes low or the flow to the lungs become low, the amount of carbon dioxide reaching here will become low. So the amount of carbon dioxide getting into the alveoli will be low. So your ETCO2 will become low. That is clear? That is clear? Is that clear?
Yes.
If amount of carbon dioxide reaching here is low, the ETCO2 will become low, and that's why you get ETCO2 to be low. Okay? So now if I give very high PEEP, if I give extremely high PEEP, this will press upon my capillaries. So if the alveolus is compressing the capillaries, the amount of carbon dioxide going there is lesser, the amount of unloading becomes lesser. So the gap completely changes. समझ रहे? The gap completely changes. Correct?
So
What?
CVP and 4Ds have to be done.
कौन सा विज्ञान मिशन?
नहीं sir, वो like bed of 5
हाँ. Who was in the night? Ankita. Which patient? Bed number 5. We wait for some time. है ही नहीं क्या कुछ भी हमारे पास.
5 वही हुआ ना सस्पेंस IV
IC
एक्शन
not
नहीं
getting
getting
नहीं है.
So is it okay between half an hour? Finish in half an hour. Huh? Half an hour में चल लेते कोई problem नहीं tell her that. Huh? ठीक है, just because I want to finish this before you go. हाँ, so ये हो गया क्या high peak. Clear? So this means to say, if I change my PEEP in a case of hypoxia where I am trying to maintain my fundamentals, it is very essential that I know what my PaCO2 is. So it's not easy when I say maintain normocapnia, maintain normoxia, maintain hypotension, avoid hypotension. It's not easy. When you say the fundamentals itself is kind of quite complex when you look at PaCO2. Clear? Clear on this? So now, on a practical note, if you have a patient who is having hypotension, if you have a patient who is going hypoxic, if you have a patient who is hypocapnic, if this patient is showing any changes in EtCO2, that will trigger me to do a ABG. That will trigger me on a practical note. On a practical note, if I find any clinical deviation from what was happening till now, I need to do an ABG when it comes to traumatic brain injury. It's unlike any other case. In any other case, I'm really not bothered. In any other case, I'm really not bothered. But otherwise, I need to do a arterial blood gas because I want to correlate the EtCO2 to the PaCO2. Clear on this? Clear on this till now? So it was not easy when we said normocapnia, normoxia. No, it's not possible. It is not possible. It is not so easy at all. Okay. Now, when we say our next question is raised ICP. That is when the tears get clicked in immediately, right? So what is raised ICP? Definition.
More than
Levels
5 to 15.
Huh?
more than 20.
More than 20.
So no, well, you have to know the right. When you say definitions, no, you have to know the definition. When you say, you can't say it's something like that. So definition has to be particular. The definition is more than 22 millimeters of mercury and not transiently it has to be consistent over 15 minutes. More than 22 millimeters of mercury on of intracranial pressure for more than 15 minutes, because what otherwise will occur is you cough and the ICP goes up. That is transient. So transient way, you don't call it raised ICP. You don't kick in your management. Today, if I am on a ventilator and I cough violently, my ICP will go up and come down immediately. It will go up and come down immediately. If the initially passive, then becomes active immediately. Okay? Clear on this? So it cannot be transient rises of ICP. It has to be a rise for more than 15 minutes of more than 22 millimeters of mercury. Clear on this till now? Clear? Clear what is raised ICP? So for raised ICP, I now want to kick in to tier 1 management for raised ICP. Now, the entire thing is changing. How do I monitor raised ICP? Our problem lies there in intensive care unit in worldwide across the country. Very few centers in the world actually monitor ICP. Very few centers in the world. Believe me, I have worked in a center that used to monitor ICP, but my next hospital didn't have ICP monitoring. You understand? I mean, in an advanced country, you would expect every center to have ICP monitoring. Correct? But in the advanced country that I was in, only one hospital was actually doing it. So you can imagine, it's not that I don't have the provision or I don't have the money. It's just that people believe that it doesn't really work. Okay, it's like that. People say that it doesn't make a difference, you do this or do that. Okay, but it depends on how you work. Okay, so now when you have raised eyes, so how do we do it in our hospital? How do we do it in, first of all, what is ideal? Ideal is if the GCS is less than 8 or there is a structural lesion in the brain which has a chance of having 8 to 13, if the GCS is 8 to 13 is structural lesion in the brain or the GCS is less than 8, whatever it is, you put a ICP monitor. Okay, that is the standard, that is the guideline. Okay, that is the recommendation. The guideline or recommendation says if your GCS is less than 8 or if it is 8 to 13 with a structural lesion, you need to put an ICP monitor. That is what the guideline would say. Okay, with respect to monitoring. And when I say monitoring, there are a couple of monitoring that you think of. And you nicely explained it. You have EVD. You have
Intraparenchymal.
intraparenchymal monitoring. Then you have intraparenchymal monitoring, and then you have boards. Then you have non-invasive. The non-invasive, you have near infrared spectroscopy, ONSD, transcranial Doppler. Okay. Out of this, the best form of therapy would be actually external ventricular drain. And do you know what's the EVD? What happens? So it is not put under guidance. It can be put under guidance. Hospitals that have got intraoperative CT scans and MRI can do it under guidance. Okay, but usually it is by surface landmark technique. Now you now can understand that if the anatomy is problematic inside the brain, the surface landmark technique becomes very difficult. You understand? The surface landmark technique becomes very difficult because the anatomy, you can the surface you would put properly, but inside what is there we don't know. So in cases of raised ICP, when there is a slit-like ventricle, when the ventricle is chinked up, the whole brain is edematous, going into that lantern ventricle becomes an extremely cumbersome task. And difficult way to do it. So though we might say EVD daldo, put the EVD, it is not an easy task. It is really not. It's like hitting in the dark for putting an EVD because this is that patient who may have raised ICP. Clear on it? And not only that, among all the things that you have in critical care medicine, among the invasive things that you have, this has got a 10% risk of ventriculitis. 10% is a very large number. 10%. Okay. Everything else is 1%, 2%. But this is a 10% risk of ventriculitis. 10% is a very large number. Very, very large number. Okay. When you say ventriculitis 10% means this patient has got a high chance of being incapacitated. Ventriculitis it means. Ventriculitis means incapacitated, prognosis going down badly. So it is a very harmful procedure. Clear? And that's why it's not put in the tier of any value because it's very controversial. Others you might say tier 1, tier 2, 1 it's not there because it's a part of monitoring. And the harm is too high. 10%. Okay, 10% ventriculitis, chance of ventriculitis. That's why it's a. But other way around, it is the best form of monitoring. Why is it the best form of monitoring? Because the others are not as good as this, and the others don't have the capacity that this can do, and that is primarily draining the CSF. Okay, it's therapeutic. That means to say, if my ICP goes up, just like a tap, I just open it, the CSF goes down, ICP goes down. It's as simple as that. Not only that, it also gives me waveforms, helping me to interpret the brain's condition. We'll come to that in a minute. Why is it? What about the rest? The rest when we talked about intraparenchymal transducers. These are those that are put inside the brain parenchyma. Now, when you put it inside the brain parenchyma, you can't take out CSF from that. Here you're putting in the ventricle. There is a drain inside. You can actually drain it. Whereas when you're putting in the intraparenchymal tissue, it's like a fiber optic sensor. It's actually a pouch technique. You put it inside, it will tell you that area's ICP. It doesn't tell you the global ICP. It tells you that area ka ICP. So it's a big controversy. If I have a right side IC bleed, where do I put it? Do I put it on the left side? Because it is largely giving you regional. You understand? Largely it is giving you regional. Not only that, this is lying over there, slowly and steadily some tissue will come, something will get attached to it, something will change inside, and the number will drift. The number will drift from what it's supposed to be. Initially you saw something, now the number is drifting. So the problem with intraparenchymal bolt systems or intraparenchymal systems is the drift also that comes in. The drift. Okay. Today you have the ICP to be okay. In a couple of hours or days, the ICP will again start changing, and you may not know whether it is the ICP changing or it is the drift occurring because of the probe that's lying inside. You understand? Though it's a phenomenal way of monitoring, because once you put a bolt inside, not only you can monitor the ICP, but also you can monitor an important value called as PbTO2 or brain tissue oxygen. Brain tissue oxygen. So you know the brain tissue oxygen at that particular moment, and which we say if it is less than 15, you have to initiate management quickly. So it also gives you PbTO2. Like how we say PaCO2 and PaO2, it also gives you PbTO2. It also gives you PbTO2. So you cannot say that this is something that is not giving me any more. It can give me even that. It can also give me the same intracranial bolt can also give me brain temperature. So the patient may have a temperature that is normal, but the brain temperature, if it is high, it is a problematic situation, which is possible. So it also gives you brain temperature, the temperature of the brain. You understand? So it's giving you the temperature of the brain. Just now you was talking about normothermia. One of our fundamentals is normothermia. Now our fundamentals is normothermia. So in our fundamental management, this can make a huge difference because we'll exactly know whether the temperature is normothermic, hypo or hyper. Clear? Because that is our end result. Our end result is not the body, end result is the brain. So you get PbTO2, you get brain temperature oxygen apart from your ICP in these monitors, and that's why these monitors are very, very good monitors. But the problems you want to know is the drift that will occur. The drift that will occur because after all it is lying in the brain parenchyma. समझ में आ रहा है? Clear on this till now? And the problem also is it is regional. It is not global. It is not the whole ICP. When I say intracranial pressure, it is the whole brain. It is not one part of the brain. It is the whole brain that is having a raised ICP. समझ में आ रहा है? Clear on this till now? Clear? So that is PbTO2. Then you have these bolts. It is the least infective of the entire lot because this bolt is not touching the brain. It is touching the subarachnoid space. It is touching the subarachnoid space. Okay? So among all this is the least of the problems, but it has got its own issues. Okay, that comes in with bolts per se. This also has a characteristic drift that occurs, which is problematic, and it cannot really aspirate anything. It cannot really aspirate anything, so it's not therapeutic. Okay, so that is submural bolts. Clear on this? Clear on this? On the non-invasive part, we have other issues. For example, when you look at optic nerve sheath diameter, it is only an association. We say that if it is very high, then there's a problem. If it's normal, the ICP can still be high. Are you understanding? So, on a transcranial Doppler, pulsatility index is something that you can look at to understand whether raised ICP is there or not. But it is an expensive device. It has got huge operable, every operator may interpret it slightly differently. You need very expensive probes on that. So it is an expensive device, a transcranial Doppler, but it is a device that you can use for trending. Clear? It's a device you can use for trending. Now, in our given scenario, we are not immediately putting AEDs. We don't have intraparenchymal bolts. Transcranial Doppler, we are not using per se. The only thing we are using is optic nerve sheath diameter. And the most important thing we are doing is clinical signs and symptoms. So we are left with clinical signs and symptoms and our history that tells us this, and our only one imaging finding that we have from a CT scan. So that is why, as a doctor in the intensive care unit, you should be able to predict whether there is raised ICP or not in this particular patient, looking at general condition. So in short, if the GCS is less than 8 or it is less than 13, which is called as moderate brain injury, if less than 8, it is severe brain injury. Okay, if it is 8 or it is less than 13, you have focal neurological deficits, you have disordered posturing, disordered breathing, pupils are not reacting well, they are sluggish or they are unequal. Any of these features would tell you, or an ONSD that is high, will tell you that the patient has got raised intracranial pressure and I have to move from fundamental support to a tier support. Clear this? I have to move from a fundamental support to a tier support. I can't just give fundamental support here. Clear on this? That's why as a bedside doctor, it's very essential that you figure out whether the patient has got raised ICP or not. Start to go there. Very annoying. Start working there. Clear on this? Clear? Understood this? So understood when we can move from this to tier support, right? So as a doctor in the intensive care unit, you have to be vigilant enough to say, we have to move from here to here. We have to do something here. Correct? So you move from fundamental care, that is preventing worsening, to now therapy. You are moving fundamental care to therapy. Clear till now? Clear?
Yes.
It's not been easy till now, if you ask me. It's not been easy till now. Okay. Now, before we get into the tiers of support, there is a very important thing that I must tell you is understanding the waveforms when it comes to ICP. You may not see them, but tomorrow when you are giving an exam, tomorrow when you are in the ICCM exam, European Diploma, MRCP exam, DNB exam, this comes as a question. This comes as a question. These waveforms. Because we are expected to know. So there are 3 waveforms. So when you put it inside the brain, you will see something like this. This is what the waveform will be. This is called P1, this is called P2, and this is called P3. Okay, this is what it's called. This is called as percussion wave. This is called as tidal wave, and this is called diastolic wave. Okay, this is where the diastolic notch is coming in, aortic. From the arterial line, that is where the aortic valve closes. Similarly, that is where this is also happening. What you should see is that P1 has to be less than 80% of P2 has to be less than 80% of P1. We have to see that the P2 is less than 80% of the P1. Okay, that is very important. And when you call it raised ICP, when it goes from here and the P2 becomes big, this way. So this is raised ICP. This is also called as compliance wave. The tidal wave is also called as compliance wave. इसका मतलब ये है कि अगर if your waveform starts looking like this, that means the compliance of the brain has gone very bad, and you have to go from tier 1 to tier 2. If it's tier 2, you have to go from tier 2 to tier 3. You getting the point? Huh? This gives you an idea that where you're moving, which tier you're moving from. So this means this compliance of the brain has gone very, very bad. I need to quickly act. Clear? Huh? So these are also called as Lundberg's waves. These are all called as Lundberg's waves. There are A, B, C, D waves, but we are only going to talk about this wave. There are other waves also, A wave, plateau wave, C wave, a lot of things are there. But then you're going to look at only this, because this is what you basically asked in your exams, and this is what as a bedside doctor you should know also. Okay, meritorious going high, and then you will have the other waves coming in. But as of now, for background
I
baseline.
see these waves like connecting the EVD to something translucent.
So how is this? So that comes. So how is the EVD? How does the EVD look in the first place? So the EVD is a device. You have the brain. Okay. Here your external your catheter is lying inside the ventricle. Catheter lies in the ventricle. From here a tubing goes like this, and usually at the level of the pubic symphysis or the external auditory meatus, usually pubic symphysis, you are keeping a transducer. The transducer is attached to a stand. And just like a transducer का एक वायर होता है, वो एक वायर जाता है मॉनिटर को. तो जैसा तुम आर्टिकल लाइन देखते हो, इस आर्टिकल को ट्रांसड्यूसर लगता है, वैसे ही वो ट्रांसड्यूसर उधर लगता है. The only difference is हम लोग इसमें ना प्रेशराइज नहीं करते हैं. जैसे आर्टिकल में क्या होता है, you have an arterial, this and you put a pressure of 300, वो प्रेशराइज नहीं करते क्योंकि पानी अंदर चला जाएगा. समझ में आ रहा है? हाँ? So we don't pressurize the system. It is just a system that looks exactly like this, but don't pressurize the system. समझ में आ रहा है? हाँ? It has got an opening here. So if by any chance your ACP is going up, on you see a wave that on this waveform that goes like that, you just open this so that it drains the CSF. So at the end इसके नीचे ऐसे एक बैग होता है, ऐसे लटका रहता है बैग. समझ में आ रहा है? Clear on this? This is how it looks. I have it. You can see it. I have this device lying inside my teaching cabin. You know, I mean, ask them. They may use it. She would have kept it somewhere. ठीक है? So this is your ICP contraption. ठीक है? So you understood percussion wave, compliance wave, diachrotic wave, and P1, P2, P3. P2 has to be 80% less than the P1. And if the P2 goes up and stays up, it means the compliance in the brain has come down and need to move from tier to tier. Tier to tier, correct? Clear on this? I don't want tier to tier. Clear on this? So as far as possible, if I have to move from tier 1 to tier 2, I need repeat imaging. If I have to move from T1 to T2, I need to do repeat imaging. That's very essential. Okay. So today, if you are on certain X amount of sedation, or you are moving from mannitol to barbiturate coma, I can't do this without having an imaging in place. It is essential that you have an imaging in place. Somewhere is essential because that will give us more information as to what's happening inside the brain. Are you getting the point? So the first tier was what? Prevent. 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 Worsening. Prevent worsening. The first thing is always prevent worsening. You must remember it like that. Then you can remember कि मैं क्या कर रहा हूँ to prevent worsening. Okay. The second is always reducing. Correct. Next is reducing volume in the brain. And so that I want to reduce volume in the brain, what do I need to do? Osmotherapy. That's where osmotherapy comes in. That's where sedation comes in. Okay. So osmotherapy comes here. Sedation is already here, but here the sedation is regulated. Osmotherapy. Now in osmotherapy, what are the two things you want to use? You want to use mannitol and hypertonic saline. Now so let's take the example in our ICU. Okay, you have a patient who comes in and suddenly, let's first understand why Why do you want to do this? Why do you want to do this? Why is this? What is this called as? What is this therapy called as?
Hyperosmolarity.
Osmotherapy. That means what am I actually fundamentally doing inside of the brain? I'm increasing what in the brain?
Salutes.
Correct. That means I'm increasing the tonicity. I'm increasing tonicity. This is exactly what I'm trying to do. What am I trying to do? Increasing the tonicity. That means I'm increasing the tonicity of the brain. Correct? And to increase the tonicity of the brain, I'm giving more amount of solutes inside. When that happens, we are expecting the brain to actually get dehydrated in some manner or reducing volume in some manner. And rightly, how does that happen? In mannitol, how does it happen? In mannitol, there is good. No. He explained this very beautifully.
Capillary, it stays in capillary.
Dehydration of the erythrocytes.
What?
Dehydration of the erythrocytes.
No. I mean, he explained it very nice.
Reduce the reflex.
No. So what it does is, you were sleeping when he was.
It stays in capillaries.
What? How does it do this?
So mainly it reduces your blood viscosity.
Correct. That's the answer. So the answer has to be, it alters the rheological properties of your RBC. It alters the rheological. That means the deformability of your RBCs, the movement of your RBCs. It changes that. Since it changes that, the viscosity of blood is actually changing. So when the viscosity changes, suddenly the brain sees, there is the suddenly viscosity. Suddenly I'm getting large amount of blood into my brain. So there is a metabolic coupling that occurs because of autoregulation at that moment. The moment that metabolic coupling occurs, it sees the brain, it vasoconstricts. And when it vasoconstricts, it is actually removing the volume out. Correct? That's the thinking. Not only that, we are also thinking of other manner. Let's take the example that you have a patient who is a tumor. Now this is a patient who's come with a tumor. Okay, he had a large tumor in the brain, and that large tumor has suddenly increased in size or has created raised ICP. There is a large tumor that has increased in size and caused raised ICP. Okay, raised ICP. Now, since it's a tumor that has caused raised ICP, what will you do now? The principle being the first, we want to do the first tire. The first tire is what? Reducing?
Volume.
That is tire 0. Worsening is reducing. First thing, reducing volume. So what will I do in such cases? Say till now you understood, I'm going to diurese, I'm going to remove volume, I'm going to ensure that is happening over there, sedation I'm keeping. What do we do in tumor? No.
Steroids.
Steroids. Now that's the difference. That's the difference in what I'm thinking. Mannitol will not work. Why will it not work?
Because we.
the tumor's volume is different, but it's not.
What kind of edema you have? No, it's vasogenic. I explained to you all last time. So you have two types of edema. You have cytotoxic and you have vasogenic. The cytotoxic edema is the one that occurs with ischemic strokes. You have a stroke, blood supply is coming down and the blood supply goes off. And that is cytotoxic edema. Under the cellular components, it's bad. Ischemia. Whereas vasogenic is when your blood-brain barrier has a problem. Okay, so when you have a tumor in your brain, your blood-brain barrier is gone for a toss. Number one. Okay, since your blood-brain barrier is gone for a toss, the podocytes that are holding the endothelium is actually weakening off, and that is why molecules that are inside the cell are getting out. Inside the vessel is getting outside. So you have interstitial edema developing. Correct? So the tight junctions that you have that are going for a toss, the tight junction proteins, because of which there is leak, and that's why it's called vasogenic. The vascular system giving the edema outside. Vasogenic. Okay, the tight junctions are going down. Okay? Not only that, this also causes a release, because it's a tumor and the blood-brain barrier is destroyed, it causes a release of IL-1 and TNF-alpha. Interleukins and TNF-alpha, which are cytotoxic mediators, which are basically inflammatory mediators, which also increases this vascular endothelium permeability to actually increase. Okay? Clear on this? So that is the second thing that occurs. So in that case, that's why the treatment for this would actually be, we are not removing anything, we are trying to prevent further transudation by actually starting the patient on steroids. So what would be the dose? So if you have a patient with that comes to you, you need a dose for everything, right? What is the dose? Sorry? So this is a tire of management. This is not something I am doing maintenance. This is a patient with raised ICP. I either get it down now or the patient worsens. So you need to give a dose that will act immediately, fast, and in the right amount. That's why it's 10 milligrams. That's why the dose is 10 milligrams of dexamethasone, because we don't want the mineralocorticoid activity. We want more the glucocorticoid activity. Dexamethasone is more glucocorticoid, faster acting drug, and that's why we give it as 10 milligrams of dexamethasone stat, and then you may want to keep a maintenance of up to 16 milligrams per day. That is 4 times a day, 4 times a day. Correct? We may start 4 times. It's a slow taper compared to what we're doing with mannitol, compared to what we're doing with hypertonic saline. Very different management in tier 1. When it comes to tier 1 management for a patient who's had vasogenic edema, the entire thing is changing to steroid management. So 10 milligrams stat, 4 milligrams 4 hourly is what 6 hourly is what I will probably give to these patients, because I want to immediately get that ICP down. The only way I can do it is by steroids. Clear? Clear on that? And then, unlike mannitol, where I, how long, how that is very short, this is like slow taper. It's very different. You're getting the point, it's a slow taper. I would not probably taper it immediately. I'll taper it over some weeks. Clear? Clear on this till now? Tier 1 management समझ में आ गया? For that, now comes the dose of mannitol. So what is the dose of mannitol? So last time we discussed, but what is the dose?
150 to 200.
So the dose is actually now that you understand what I'm doing with mannitol, the other thing that we use is 3% saline. Okay, mannitol and 3% saline. That is what you're using now. It's not so simple that okay, mannitol de do. So the dose of mannitol to reduce ICP is somewhere between 0.5 to 1 gram per kilogram. 1 gram per kilogram. Okay. There are certain papers that say 2 gram per kilogram. Okay, but let's take 1 gram. Okay, 1 gram per kilogram means if I'm a 70 kilo individual, it is going to be 70 grams. 70 grams. Now 70 grams, each 100 ml of mannitol contains 20 grams. So for 70 grams, how much do I need to give? 70 into 100 divided by 20. 2 5s are 10, 350 ml. Okay? It is 350 ml of mannitol that has to be given quickly. You understand? Because what is your assumption? The assumption is that ICP has gone up and I need to get that ICP down. I need to do this. It's not an osmotic effect. It is a rheological properties. That means immediately it has to go in. If you give it slowly, the rheological properties will not alter as much. It has to go in quick, and rheological properties has to alter in the brain, and cerebral vasoconstriction should occur. Clear? Clear? So similarly, you have 3% saline. Similarly, you have 3% saline. Okay. So 1 gram of mannitol is equal to 5.4 ml of 3% saline. Okay. It's 5.4. So that means your 3% saline dose will be somewhere in the dose of 300 to 500 ml. 300 to 500 ml if you have reached ICP. Okay, very large amount. If you look at it, very, very large amount of 3% saline that you need to give. It's not simple. Okay, and that's why you can have side effects that come from both these therapies. Understand? Because the doses that you're using are not the usual doses. I am not using 100 ml for osmotic diuresis. I'm not using 150 ml that I use for my 3% saline when I'm having hyponatremia. What am I using? I'm using almost triple the dose. I'm using a triple dose of 3% saline and almost triple the dose of mannitol. Otherwise, what I'm comfortable with. Correct? So it's but obvious that if I'm going to use any of these medicines, there is going to be umpteen amount of side effects. Now you can understand the risk of therapy is going higher. You can understand the risk of, so when I come to tier 1 and I'm using osmotherapy, my risk of therapy is going higher from what it was before this. Okay, risk of therapy is going higher than what it was before this. Are you understanding what I'm saying? The risk of therapy is gone even more higher now. Because why? Toxicity. Okay, toxicity. Okay. Not only that, what also practically is a problem? The speed. I have to give it fast. Now if I say 3% saline, she goes and indents it and gets it, and this is the situation in all countries. Okay, it's not only in India. You want to give 3% saline, it comes from the pharmacy because it is a scheduled drug. It is a drug that can cause be toxic. They don't want to keep it on the shelf. Mistakes हो जाएंगी. अगर तुमने 3% saline को 9 से क्या कर दिया तो वो लोग 3% saline उड़ा के दे देंगे. So it's not kept on shelves. That's why 3% saline is not kept on shelves. Mannitol is not kept on shelves. They are kept in the pharmacy. समझ में आ रहा है? हाँ. So it takes time to come from the pharmacy. Any hospital in the world, it takes time to come from the pharmacy. Unless you have the pharmacy inside your ICU. Okay, which some hospitals now have. ठीक है? Unless you have the pharmacy inside the ICU, it takes time to get that mannitol or the 3% saline. ठीक है? So what is the alternative? What am I trying to do here? What am I trying to do here? Increase the
Volume.
by doing which therapy? Hypertonic hyperosmolar therapy. So what is the easier option? What you have generally in the ICU every given moment? You don't have it every given. I just told you it's in the pharmacy. What do you have? You have sodium bicarbonate. It's the same thing. You have sodium bicarbonate. It's exactly the same thing. Okay, you have sodium bicarbonate in it. Sodium bicarbonate has got sodium in it. It is hyperosmolar. So what stops you from doing it? Nothing. Give 150 ml of sodium bicarbonate, which is equivalent to 530 milliequivalents of 3% saline. समझ में आ रहा है? हाँ? Give 150 of sodium bicarbonate. Immediately give 150 ml of sodium bicarbonate. Don't wait for the 3% saline to come in. Just give this. समझ में आ रहा है? 150 ml because it is equimolar to your 3% saline.
मतलब bicarbonate will cause CO2.
No, because we are in control condition of ventilated patient. It's a ventilated patient. The only thing that this can cause is metabolic alkalosis. It can cause hypokalemia. You have to keep vigilant for that. You have to be vigilant for that. But my bigger picture is my ICP is coming down. Na? My bigger picture is that. What this patient is going to go down because of ICP. If I'm going to say 3% saline, they do sister 350 ml. Now you will go ask from sir कितना है वो 350 से 350 देना है क्या? फिर 3-4 तुम मंगाओगे. 3-4 आएगा नीचे से. By the time the patient it comes from there, it is 20 minutes. It is 20 minutes. Our response time is 20. It comes in 20 minutes. So it comes in 20 minutes. Unless it's a stat, it comes in 15 minutes. Okay. So अगर वो stat is also 15 minutes, so someone has to get it. तो time लगने वाला है. हाँ, time लगने वाला है. वो time लगने वाला है. हमारा ICP बढ़ता रहेगा. Patient will actually go down. And that is the reason that the easiest option for you in the given scenario is take 150 ml of sodium bicarbonate and just push it inside. And it is much more convenient for you if you think in your brain. I am okay giving 150 ml of sodium bicarbonate, but I may not be okay giving 350 ml of 3% saline. I may be scared to do that. If you think about it, you understand why? Because there are side effects. There are side effects. The sodium is going to go up. The sodium is going to go up. If the patient is already coming with a hypotension, there is going to be renal failure. Because I am stressing the kidneys osmotically to actually pass that urine out. Then it comes to mannitol. And that is why mannitol is a contraindication in renal failure. It's a real contraindication in renal failure. Clear on this? And that is also the reason that there is a rebound effect of mannitol. You give mannitol in the morning, there is a rebound that occurs in the evening. Okay, so there's a rebound effect that comes in. Clear on this? Clear on this? That's why mannitol 3% saline se acha is to give sodium bicarbonate. Clear on this till now? Now remember this. He always said in the middle that you want to keep the sodiums in this patient on the higher side. You want to keep the patient's sodium on the higher side here because you want that hyperosmolarity to remain there. It is going to help the patient with the hyperosmolarity. So my required sodium here is above 150. So 150 to 155. Okay, I want to keep this between 150 to 155. And that is why as a bedside doctor, when I'm looking at 0 or 1 somewhere here, I need to understand how to manipulate my sodium. I need to understand how to manipulate my sodium because I want to keep it at 150 to 155. How do you do this? What is the simplest technique? So there is the Adrock-Medeiros formula. Adrock-Medeiros formula. What is the Adrock-Medeiros formula? Anyone knows? The change in sodium into 1 plus weight upon sodium of the solution minus sodium in the body. ठीक है? समझ में आ रहा है? I'll explain to you. The change in sodium. So if the sodium is 145, I want 5 of change. हाँ, I want 5 of change. Clear on that? हाँ, मेरे को 145 से 150 लाना है. I am trying to figure out मेरे को कितना सोडियम डालना है ना, उसको उतना लाने के लिए. तो इसको मैंने 5 एरोमेटिक डाला into 1 plus weight of the patient. से 50 किलो का weight है. हाँ, and percentage body water कितना है उसका? For an adult male female it is 0.5, for an adult male it is 0.6. Right? So into 0.5 का female पकड़ लेते हैं. हाँ, upon the sodium in the solution. So our sodium in our solution for 3% is 513. Huh? 513 minus the sodium in the body 145. This will give you the mLs of 3% saline. Okay, I don't want to remember this formula. I want to keep this smaller. So the simple idea is weight, change in sodium into weight into 1.33. This is simple formula. This actually I have made this formula into this formula. That's how I remember it. When you all call me, that's how I remember it. So it's just the Adrock-Medeiros formula. Adrock-Medeiros formula. Adrock-Medeiros formula. That's the formula you should remember. Adrock-Medeiros formula. Which is this one. Which is the change in sodium into the mLs of 3% saline is equal to change in sodium into 1 plus body weight into the body water content. So for adult males 0.6 and adult females 0.5 divided by sodium of the solution that you intend to give, that is 3% saline. For example, 6% saline will be different here. It will be 1026 minus 145. What is the patient sodium? Clear? If I were to make this formula and make it compact and I remove all these numbers from here, I just retain the weight from here. The answer is mLs is equal to change in sodium into weight into 1.33. Let's take the example that you have a patient of 145, the same patient, 145. How much change of sodium we require? 5. So 5 into weight. Let's take the weight as 60 kilos. Into 1.33. 5 6 are 300. Into 1.33, that is 3 3s are 9, 3 1s are 3, 390 ml. So amount of sodium I require to actually make the sodium 155 in the whole day is 390 ml. So now I divide it. 10 ml per hour, 20 ml per hour, 30 ml per hour, and I'm expecting that will go up. So
390 whole day.
Whole day. Whole day. Well, 390 I can give whole day. I can give it even immediately also it will go up. But I don't want to change the ICP. I'm not maintaining, no? Maintenance I don't want to give as bolus. So maybe I'll give 150 ml stat and then I'll make it at 10 ml per hour. You getting the point? So whereas sodium will go up because I don't want to overshoot also, because if I overshoot by more than 8 milliequivalents in a single day, it is dangerous. I don't want to overshoot between 8 milliequivalents per day, 18 milliequivalents in 48 hours. I don't want to overshoot by 8 milliequivalents in a certain one day or 18 milliequivalents in
20. 40.
ठीक है, 8 milliequivalents in a single day. I am keeping it on the lower. Actually, it is 12 and it is 24. But we are keeping it more conservatively so that we never overshoot. You understand? Keep more conservative. So 8 milliequivalents in a single day or 18 milliequivalents in 48 hours. समझ में आ रहा है? Interesting. So now, however, our body is not a beaker. Our body is not a beaker. अपना सोडियम निकल भी तो रहा है. ये तो हमारा, it's like, okay, maybe this is the way you do it. Okay, but our body, if it was a beaker where it remains inside the body, and there is no urine coming out, then this formula will work. Right? But our body is not a beaker. Volume also coming out, and that is the reason that irrespective the formula, this is only a guide. So for 4 hourly, repeat the sodium till you are certain about it. You understand? Till you are certain about it. That is why yesterday when somebody asked me, there is a patient of CKD over here, shall I give 3% saline to increase it, increase the sodium? There is a patient over here. Yesterday you asked me?
Ashutosh Vaidya.
There's a patient here, sodium come hai, 3% saline de dete kya? That patient is CKD. He is like a beaker. There's a possibly having overshoot so crazily that it may go haywire, and he is otherwise stable, so I don't want to do it. Clear? Clear on this? Huh? So even if you have a guide of how to replace the sodium, you have to rely on a laboratory management. You have to look at the laboratory. So now you have to look at the laboratory, because if you were to actually overshoot, there is a chance of
Point time management.
osmotic demyelination syndrome, ODS. Osmotic demyelination syndrome. And it was initially called as central pontine myelinosis. Why is it called that? What is happening? What is this? What is this osmotic demyelination?
So basically the only the eye movements are there and the.
So what is happening inside the brain? What's happening?
Sodium is
What is the meaning of demyelination? It's like that patient there, no?
Yeah.
That AIDP patient there. Demyelination. But this is occurring in the brain.
Yeah.
You understand? But demyelination is occurring to that guy. He was almost paralyzed when he came. He is now occurring to the brain. It's occurring to the brain. That is demyelination. But why is it occurring? It's occurring because what happens usually is when the sodium in your body is predominantly low for a long time.
Yeah.
So let's take it as 120. You have the astrocytes. You have the astrocytes. Now तुम्हारा इधर sodium कम है. The brain is understanding the sodium कम है. तुम्हारा vascular endothelium, growth factor, endothelium, all this is realizing. The body is realizing the sodium outside is less. I need to do something to improve that. I need to do something to improve that. तो क्या करेगा? वो यहाँ से सोडियम बाहर निकालेगा अंदर से. समझ में आ रहा है? सोडियम के साथ साथ there are other elements, organic solutes that are coming out. They are called as osmolytes. There are organic solutes that are adding to the osmolarity outside the brain cell, outside the astrocyte, which are called as osmolytes, organic substances. Clear? मेरा सोडियम अगर आज 120 है और सैटरडे को भी 120 रहा, my body is adapting with such a way that nothing is lying inside, everything is now outside. This occurs only when the sodium has remained low for more than 48 hours. Clear? It has remained low only more than 48 hours. This is occurring at that time. Clear on that? If it is less than 48 hours, this is not occurring. Okay? But this adaptation is occurring only once the sodium has been low for 48 hours. I'll explain this again. Astrocytes, there are osmotic solutions lying inside this, because of which the cell is lying nice and inflamed, nice and big. Okay, now you have made the osmolarity outside the brain to be 120. Now it is moving the sodium electrolytes out from here, also the osmolytes out from here. And as it is moving in 24 or 48 hours, the entire thing, this sodium is, it's trying to push it towards, sodium is not going up. But because of the osmolytes that have come out from here, the osmolarity has got better. The sodium is really not pushing up. दूसरा sodium तो कुछ होने नहीं वाला यहाँ से. It is getting better because the osmolytes that have come out from the astrocytes are taking over the osmolarity. समझ में आ रहा है? Now what happens? You suddenly give the patient 3% saline. Suddenly. You give suddenly 3% saline. What ideally should occur? Ideally ये 120 का मैंने 150 कर डाला. What ideally should occur? Ideally क्या होना चाहिए? Suddenly ये side hyperosmolar हो गया है. Because actually normoosmolar है. Actually normoosmolar है. मतलब उसको everything is moved. What should ideally occur? What should occur? Actually what should occur?
Cellular swelling.
No, what should occur? What should occur if this goes up to 150? What should the cell do?
Fluid shifts.
Fluid is not osmolarity. What it has to shift? Solutes. Yeah, it has to shift back whatever it took outside, inside. This has to take place. This has to take place. This has to take place. Correct? Otherwise it will become dangerous. 150 इधर आ गया. It has to take place. So the movement of the sodium may occur, but the movement of these organic solutes don't occur. Okay, because that takes time. You understand? That takes time. समझ में आ रहा है? तो आप
It is like gradient is made, that's why solutes are also going and.
But it
sodium.
takes time. The problem with the organic solutes is that takes time. Adaptation उसका ना, it takes time. That's why I said slowly adapted. समझ रहे हैं? 48 slowly adapt हो रहा है, धीरे धीरे adapt किया उसने. ठीक है? समझ में आ रहा है? slowly adapted. But if the person is you're giving sodium suddenly, it is slow adaptation. वो जल्दी adapt नहीं कर पाता है वो. समझ में आ रहा है? Slow adaptation है. तो organic solute जो है सोडियम निकल जाएगा. Organic solute से वो मूव नहीं होता. ठीक है?
सोडियम विल कम।
हाँ, so ये सेल क्या होगा? श्रिंक हो जाएगा. क्योंकि जो पानी है वो निकल गया. समझ में? पानी ऐसे निकल गया. पूरा स्ट्रेंथ सिंक हो गया. उसकी कवरिंग कट गया. That's why demyelination. समझ में आ रहा है? Regarding the point, समझ में? I'll explain this again. You have an astrocyte. The astrocyte had a lot of material inside. Now the sodium was on the lower side. If the sodium was on the lower side, what did it do? It tried to move some sodium here, लेकिन उतना ज़्यादा sodium होता नहीं है इसके अंदर. ठीक है? वो क्या move करता है? Organic solutes. That's called osmolytes. It moves those osmolytes outside, which takes long time to move. Slowly and steadily the patient gets adapted. For example, first the sodium goes down, patient is drowsy. Our usual scenario. हाँ, फिर धीरे वो 130 पे adapt हो गया है. अभी 130 उसका normal sodium हो गया है. 130 की normal sodium हो गया because the organic solutes have actually moved out and the interstitial osmolarity has become normal. तुम्हारा सोडियम भले ही 130 है, फिर भी वो जी रहा है. उसका सोडियम भले ही 125 है, फिर भी वो जी रहा है, मर नहीं रहा है वो. हाँ, उसको प्रॉब्लम हो रहा है क्योंकि the organic solutes have come and taken its place and that is why the interstitial is still proper. समझ रहे हैं? Now in this scenario, if I now put a huge amount of sodium here, ideally what should happen? What will happen? Ideally these all things that were out should go inside, no? So because if 150 suddenly आ गया huge amount, समझ में आ रहा है? So this whole thing should actually go inside. Unfortunately, it doesn't go inside. And what unfortunately occurs? Water comes outside. Not only water comes outside, the solutes are remaining outside. They are not going back inside. So there is a huge amount of problem that occurs because of which there is demyelination. Cell shrinks and demyelinates. Okay, so when they demyelinates, which cells will demyelinate more? Those cells that were more active. The pons is our more active system. In our brain, the pons is the most active system, most metabolically active. That system, and that's why you get central pontine myelolysis. That's why that's the first thing that comes infected because of osmolar demyelination, and that's why we call it CPM. But it's not necessary that it will be the pons, it can be any part of the brain. Okay, because it was occurring more regularly in the pons, ODS was linked to CPM. ODS, that is osmolar demyelination, was linked to central pontine myelolysis. Right? But it can occur anywhere, and that's called extra pontine myelolysis. So you call this syndrome as osmotic demyelination syndrome, which might be either central pontine myelolysis or extra pontine myelolysis. समझ में आ रहा है? Clear? I can't let that occur. And this is exactly what's happening when I'm giving 3% saline like this. Are you getting the point? This is exactly what's happening when I give 3%. That's why the maintenance is given slowly, so that it slowly goes up. Now you got the point? Huh? You got the point? समझ में आ रहा है? That's why I'm regulating my doses and that's why I'm following up my sodiums.
So, but this will happen only when in a patient who has chronic hyponatremia.
Correct.
Otherwise,
but what are we doing here? We are having a patient of 140 and I'm taking it to 155. It's a 15 milliquin price. The same will occur even in these patients. He is he adapted because what has happened that 140 में osmolytes तो है ना भाई. And now you have made it hyperosmolar. You getting the point? Cell shrinkage, demyelination. That's our problem. Getting the point? And that is the reason that we have to follow it up. But fortunately, God has created it such that demyelination occurs only when you correct by more than 18 milligrams in 48 hours. So समझ लो तुम्हारा शूट हो गया. First दिन तुमने किया, तुम्हारा 140 था, तुम्हारा 155 फर्स्ट डे पे ही आ गया. मतलब फर्स्ट डे पे तुमने सुबह चालू किया, दोपहर शाम को 4 बजे तुम्हारा 155 हो गया. 15 18 हो गया, ऑलरेडी 18 हो गया. लेकिन तुम्हारे पास एक दिन है करेक्शन के लिए. 48 hours. You have 48 hours of correction. In that 48 hours जान लगा के उसको करेक्ट कर लो. समझ में आ रहा है? हाँ, उसको फ्री वाटर दो, क्या करना है, 5% एक्स्ट्रा दे, क्या करना है दे दो, लेकिन get it down. So you have 48-hour window period. You understand? You still have 48-hour window period. Getting the point? I'll explain this again. तुमने अभी ये पेशेंट आया, तुमने उसको 3% सलाइन दे दिया, 140 था, वो 155 हो गया. You're not saying, wow, I did a great job. I might create demyelination.
Yeah.
But this has occurred in 24 hours. I have a next 24 hours remaining where I can get this back to say 150 or something like that. समझ में आ रहा है? Clear? Huh? Any doubts till now? And for that, you must remember that in order to actually Then we'll come to the sodium later on. But this is clear till now? Huh?
Then better is the mannitol only, because there is no such side effect, like because I've seen POMS patient, pontine melanosis patient. So better is mannitol.
So the question is, what is better in that context? For example, you have raised ICP. For raised ICP, I have both 3% saline and mannitol. Both of them work equally well. Okay, you are looking at the side effects. Okay, 155 milliequivalents will not change the sodium by more than 15 milliequivalents. 350 is not going to do that. You are getting the point. But if you look at the benefits, for first thing was prevent worsening. Prevent worsening. You give mannitol, patient passes a ton of urine, your hypotension, hypovolemia will occur, and worsening will start. You have to be vigilant. You have to be vigilant, because that if you are vigilant, mannitol is equal. If you are vigilant, mannitol is equal. If you are vigilant enough to understand this problem, you should be vigilant enough to understand this problem. You getting the point? Other way around, you have a patient renal failure. You have a patient with your patient who is already having trauma coming with hypertension. I don't want to start this patient on mannitol. It is one of those patients that will not do with mannitol, not do well with mannitol, and that is why I need to consider either sodium bicarbonate or 3% saline. Clear? Clear? So the reason for giving 3% saline is multifold. One is to improve, is to cause the ICP to come down, and two, to maintain sodium on the higher side. You getting the point? Clear on this? And these osmolar therapies will not work if your osmolarity is more than 320. Serum osmolarity more than 320, none of them will work. So that is a contraindication. Okay, especially for mannitol. If it's more than 320, I will not be using mannitol at all. Okay, how do you know that? Simple sodium and your creatinine. So if your BUN 2 into sodium plus BUN plus creatinine 1.2, the formula is there, 2 into sodium. So that will tell you exactly whether you are having high osmolarity, serum osmolarity. Clear on this? Clear? So have you understood about osmotherapy here? At the same time, in the first tier, what else do I have? I have sedation. Okay, we have sedation. So on the first tier, I cannot have my patient not sedated. And this is very different from what you do in patients who are otherwise sedated. It is very different from that. Okay, in those patients who are inside the ICU, you are sedating them. So you may or may not sedate them excellently. You may be still awake. Patient may be still awake. If you have an awake patient in a neuro ICU, it is wrong. It is completely wrong. Because one of the tiers of management in raised ICP is sedation as therapy, not sedation as putting someone to sleep. It is sedation as therapy. So if you have a patient who is awake and looking at you, though he's calm, it may be raised. That is not the way it is to be managed, because you are on tier 1 where you are suspecting raised ICP. And raised ICP ke liye, you are not letting the patient relax. You are making the patient use sedation as therapy to reduce ICP. So you can't give lower doses. It has to be good enough doses to maintain an RASS of somewhere around -1 to -2. -1, what is 0 to -1? There is a recommended agitation sedation score, RASS. When I say 0 to -1, okay, 0 to minus, in ICU, whenever you give sedation, it has to be sedation to goal. Whenever you're giving sedation in ICU, it has to be sedation to goal. And the goal is always recommend agitation sedation scale, which is there on the back of your forms. RASS, it's there back on your flow charts. RASS. And whenever you are giving patient sedation, you have to tell the nurse, sedate to RASS 0 to -1. That is what you're supposed to write on the paper also. Okay, it's an NABH recommendation that it has to be to sedation to goal. If you don't do it, it can be a medico-legal problem. RASS 0 to -1. When I put sedation, I write over there in brackets RASS 0 to -1. Okay, what is 0 to -1? 0 to -1 is if I come to the patient and I say, aake kholo, he wakes up by light touch or by sound. If the patient wakes up to light touch and sound, that is RASS 0 to -1. Light touch and sound. Clear? That is RASS 0 to -1. I don't want it there. Our ICUs are predominantly more noisier than other places. So if it's by sound, if he's waking up, it is not a good thing. I need it to be, that's why, between -1 and -2. Clear on this? So whenever you have an exam question that comes in, it comes like this. What score will you want in patients with raised ICP in tier 1? It has to be -1 to -2. Clear? It cannot be waking up with sound. So that is the kind of sedation that you must give. That is the kind of sedation you must give. Clear? But here you have a problem. We also want to neurologically see our patients. You understand? Here you have a problem. So when you're looking at this, you have put the patient on analgesia. So in this range it is analgesia. We are not yet when preventing worsening is analgesia. Because if you give the patient pain, ICP will go up. That's why analgesia comes in your prevent worsening में. Correct? But when you're coming here, it has come to sedation. You see the difference that here from analgesia it's moved to sedation. And that is why when you're giving sedation, you need to give that sedation in which I can neurologically observe my patient. And that is why the best sedation that comes to traumatic brain injury remains propofol. Remains propofol. Because it's like switching on and switching off a computer. They immediately wake up the moment you switch it on, switch it off. Clear? So you can imagine how complex now this becomes. Because you want to maintain this patient at -1 to -2. And at the same time, you want to wake up this patient. So can I just put the patient to sleep and then the patient is like that only? No, I can't do that. I can't do that. I have to maintain -1 to -2. That means I come, I shake him like this. उठ जाओ. That time बहुत ऐसा करने के बाद he kind of opens his eyes. That is -1 to -2. ठीक है? That is -1 to -2. The moment I switch this off, within some 10-15 minutes, patient should wake up. That is what I want. Clear? That is what I want. You're getting the point? That will ensure that I'm in my tier 2 management. That will involve that I'm in tier 2 management. Clear? What is the problem when I do that? The dose that we have. Remember the doses. Those are very simple. Exam में dose आएगा ना सब 3 to 5 है. Everything is 3 to 5. Everything in exams is 3 to 5 apart from dexmedetomidine. Everything. Okay. You take propofol 3 to 5 microgram per kilogram. You take midazolam 3 to 5 microgram per kilogram. You take fentanyl 3 to 5 microgram per kilogram. Only dexmedetomidine is 1 to 1.5 microgram per kilogram. ठीक है? Everything else is 3 to 5. It's very simple to remember. कभी भी कोई exam में पूछता है 3 to 5 होता नहीं. It's very simple. It's only the microgram milligram that changes. It's very simple. ठीक है? And it's the same when it comes to ketamine. 3 to 5 milligram per kilogram. Same doses. It doesn't change. It's the same doses. What is the problem with this dose? What is the problem? The problem is hypotension. I'm using propofol, which is going to cause hypotension. There our problem is coming. So it's not easy when I say sedate to -1 to -2. Our problem is coming because this patient will become hypotensive. So that comes to the important question. Avinash, what is the blood pressure you want to maintain in these patients? Since it's hypotension, what is the blood pressure? बिल्लू आंधे इसमें गर्म पानी है वो बना देना इसमें खाली डाल दे इसमें.
Have to maintain iron.
Systolic.
Little I am not making भेलपूरी में थोड़ा चटनी डाल के दे देना. नंबर होना चाहिए उसमें.
140 to 120.
क्या?
Systolic more than 110 maintain in traumatic.
What is the pressure you are worried about in your body? I mean, tomorrow if you have to take care of your own pressures, what is the pressure you are worried about? It's your mean arterial pressure.
Yeah.
So whenever we talk about pressures, we have to have MAP in our mind. You know, if tomorrow somebody wants to correct my pressure, I have BP, I look at my mean arterial pressure, not IC, not this. समझ में आ रहा है? गर्म था पर भी.
अंदर
गर्म था. ठंडा ही हो गई.
गरम करना.
उसका ऑन कर नहीं रहा. ठीक है.
MAP 70.
Is what is normal.
Yeah.
What is happening to our patient here?
What the regulation is getting.
What is happening here? The basic problem is what are we dealing with? Raised.
ICP.
So what should be your pressures?
50 to 70.
It has to be such pressures. What is CPP?
CPP is
Mass.
MAP minus
ICP.
Clear? MAP minus ICP. Now let's take the pressures. CPP I want to maintain at 60 to 70 minimum. I want to maintain this CPP. Okay. Let's take my MAP as 70. And now what did you say? I have raised?
ICP.
Raised ICP. So raised ICP is more than?
22.
So 24.
कितना हो गया? 70 minus 22?
58.
ठीक है? It is lower than 70. It is lower than 70. So can I accept 70?
No.
Once I'm in tier 1, can I accept 70?
No.
I can't accept 70. Simple. Simple. Can I accept 70? I can't accept 70. Once I have moved my therapy from not worsening to tier 1, I cannot accept a map of 70. It cannot be done anytime because I need to maintain my CPP at closer to 70. You're getting the point? I need to maintain my cerebral perfusion pressure closer to 70. So what will be my target anytime? It will be 70 at least plus 18 to 20, no? At least उतना होना चाहिए ना? Maybe 15 तो तुम ऐड करूँ मैं. If I add 15, then my target will be 85. So I am closer to 60 to 70. Getting the point? So if I am 85 and my ICP is 15, I am still close to 60. Are you getting the point? So my map target is now trending upwards. The moment I have got raised ICP and I am into tier 1, my map target now changes higher. My map target becomes higher. Sorry?
At least 85.
Correct. Minimum, no?
Yeah.
You think this way, no? Because that is why you need to know the definition of ICP. The definition of ICP is 22. That is why I must think like this, that I am going to tier 1, which indicates that there is raised ICP. And since there is raised ICP, I need to improve my cerebral perfusion pressure. And the only way I can do that is when, because CPP is equal to MAP minus ICP, I need to go higher than the ICP reading. Correct? So मेरे को at least 15-16 तो जाना पड़ेगा. That's why you go up to 85 map. That's why your map becomes 85. You're getting the point? So when I'm starting propofol, now this becomes very complex. The moment you start propofol, your BP is going to start going lower, and that is why you need to start noradrenaline to maintain the BP higher. I can't reduce the propofol. Propofol की वजह से मेरा BP drop हो रहा है, मैंने propofol बंद किया. That is not, because we are in tier 1 where my ICP is high. I need to give that propofol for the raised ICP. You're getting the point? It's like when you have hypoglycemia, I'm giving diabetic ketoacidosis, I'm giving insulin because I will give dextrose, I will give insulin because I will remove the ketones. Similarly, in this case, I have to give the propofol. I have to give the propofol, and to give the propofol, I need to give NORAD to improve the map, CPP. Finally, clear? Clear on the tier 1? Tier 1 is clear? Tier 1, so it basically involves osmotherapy and sedation. Osmotherapy and sedation is what you're looking at tier 1. And at tier 1, you're still with normocapnia. And we've understood what is normocapnia. Okay? Clear on this? Clear on tier 1? So tier 1 does not involve you to actually change the you're looking at the whole volume of the brain. So because the cerebral metabolic rate of oxygen consumption is going low, the byproducts are lesser. That's why the blood volume is not changing, but the cerebral volume is changing. Clear on this? Clear on this? Clear? So this is what is happening in tier 1. Now let's go to one step higher. You've done this. The ICP has remained on the higher side. Patient's pupils are still unequal. Patient is still having focal neurological deficits. You wake up the patient from the sleep. Patient is still not waking up. And now you are suspecting that the ICP is gone, is not getting controlled. Your marker is not there. Your ONSD still remains on the higher side. You started by saying all those things. Their ONSD was high. Your CT was showing that there was a chinked ventricle. My patient had posturing. The patient's respiration was not okay. But when I'm cutting off the sedation, it is still the same thing. When I'm cutting off the sedation, it is still the same thing. So what will I do next in 6 hours from now? In 2 hours from now, 2 or 3 hours from now, what do I do? It is worsened or it has remained the same. I'll repeat a scan first. Because I said, as far as possible, if these things are not working, I need to see the scan again. I need to see the scan again. Clear? So what I'll do, I'll repeat the scan. But at the same time, I want to now go to tier 2. Now I want to go to tier 2. Clear? Tier 1 is clear?
Yes.
Any doubts in tier 1? Now, what is in tier 2? Now, as I told you, you must remember tier 2 as somehow I'm going to reduce the blood in the brain. Somehow I'm going to reduce the blood in the brain. So what do I do here? Huh? I'm just putting it that way. I'm reducing blood in the brain. So what do I do here? What do I do then? So the first thing that hinges when I want to reduce blood in the brain, first thing that hinges in my mind, is to somehow hyperventilate my patient. Why is that so? Because if I hyperventilate my patient, there is going to be vasoconstriction. And since there is vasoconstriction, the volume of blood in the brain will actually go down. So the volume of blood in the brain will go down. That's why in tier 2 management, it hinges around hyperventilation. So the tier 2 management hinges around hyperventilation. Clear? First. So now how do you do this? And what are your targets? So our initial target was normocapnia, which we were saying, we said that we want to keep it between, sorry, ETCO to how much? 38 to 42. This was what we wanted to do. 37 to 42. This is what we want to do. Now, when I say I want to do hyperventilation, I need to keep it between 30 and 33 PaCO2. Okay? 30 and 33. PaCO2 is 30 and 33. So what should be this? ETCO2 minus 5 कर दो ना उसको. 26 to 32. समझ उससे कम in fact 26, 24 to 30. ठीक है? Somewhere around this range, 25 to 30. 25 to 30. That will be the range I will be in. So in tier 2 management, till now I was in normoxemia. Once I come here, I have to reduce blood volume. So I am coming down to 24 to 30 ETCO2. This is where I am hyperventilating. ठीक है? It is not hyperventilation जब ऐसा नहीं है. When I say hyperventilation as in I am this, it is not hyperventilation as in the real sense. You always think hyperventilation is I'm taking the ambu bag and I'm pressing hard for a long time, or I'm increasing ETCO to 35, I'm increasing the RR to 35. It is not, that is not what we are intending here. We are intending to get the ETCO2 in this range. Okay? Because that kind of hyperventilation, which you say is I'm going to increase it maximum, I'm going to press harder and harder, will cause vasoconstriction and patient will die. That requires higher management. If you want to do hyperventilation beyond this level, beyond this number, patient will have cerebral vasoconstriction, for which I need another monitor called as SJVO2 monitor. Okay, to prevent that, we need a monitor called SJVO2 monitor. समझ में आ रहा है? Are you understanding? You understood? समझ में आया? So I in tier 2, in tier 2 management, I am not using extreme hyperventilation. No. I am using hyperventilation that is very judiciously regulated in tier 2. समझ में आ रहा है? So in short, I may require to even paralyze my patient. I may also require to paralyze my patient. You getting the point? So here in tier 1 and tier 2, in order to facilitate the carbon dioxide to be good enough, like the way I want it, I may need to paralyze even here. You understand? I may require to paralyze because I want to maintain that ETCO2 like that. Are you getting the point? So paralysis has now come in. You getting the point? In the tier 1, maybe you can manage without paralysis. But once you come to tier 2, you need that paralysis because I have a very small window where I have to keep my ETCO2. And I want to regulate that window. That's why I will need to change the buttons. Patient cannot trigger the ventilator. Because if patient triggers the ventilator, it will change everything. If patient triggers the ventilator, so I am taking off the trigger because I want to be the trigger. I want to set the rate myself. समझ में आ रहा है? That is why at this stage I may require the patient to be hyperventilated. और नहीं आपने normal फोन है किसी का? बेटा हेलो क्या?